Okay, well, good afternoon. Welcome to Preventive Cardiac Imaging. I want to discuss today one of the most powerful diagnostic tools that we have in preventive cardiology. As a diagnostic tool, its function is to find disease, but as a preventive tool, its function is to find the subclinical disease before it becomes a clinical problem. And to do this, we want to balance a myriad of factors, including clinical needs, patient convenience, cost of care, and so on. So let's get some perspective first on heart disease and its causes so we can start to identify who it is that actually needs the testing. Okay, I know this comes as no surprise that the leading cause of death in the United States and developed countries is cardiovascular disease. Everybody here, I think, knows that. In fact, cardiovascular disease kills more people in the United States than the next 6 causes of death combined. So let's put this in a little bit of perspective. Breast cancer, which we hear people talking about all the time, will affect 1 in 8 women that are now 40 years old. Cardiovascular disease will affect 1 out of every 2 women that are now 40 years old. And I mention women only to make a small point as we go on our journey here, which is that people tend to forget that women have cardiovascular disease. And lest I be preaching to, I don't know, the choir or antithesis, the people that forget this most significantly are the ER docs. Because when a woman comes in and she's got atypical symptoms of heart disease, the ER doc says, well, you know, there's nothing going on here, and typically doesn't even consider that she may be having a heart attack. So that's another problem that women face. So in the United States, it affects 58 million people, which is about 20% of our population. It's, as we said, the #1 killer, and more Americans die of heart disease than all cancer combined. And we're not very good yet at identifying or at managing patients before they have a heart attack or stroke. So at least 250,000 people die of a heart attack within an hour of the onset of symptoms and before they reach the hospital. 12 million people that are alive today have either had a heart attack or chest pain. These, as you can tell, are enormous numbers that we're talking about. For men who die of a heart attack, 1/3 of them, the first symptom they have is they're dead. For women who die of a heart attack, 50% of them, the first symptom that they have is sudden death. So lots of people are at risk. The point is we sometimes spend a lot of time and energy trying to narrow down whom to evaluate when the reality is it isn't a narrow group. It's a very broad swath of the population. So, of course, we know that the desirable level for cholesterol is going to be number 5, as low as possible. It's important to point out that traditionally physicians have been saying 200. Like there's this magic number 200. This is no longer accepted by experts in hyperlipidemia, and those that are experts are typically saying 150, but the reality is as low as possible. The top number of your blood pressure should be 100 plus your age. Okay, of course this is false. But again, this is one of the perceptions in the general population. And the problem here is that people tend not to understand when they're at risk. And we're going to talk about the perception of the general population as we go on because it's absolutely critical for the prevention of coronary artery disease. Okay, so 50% of people have no identifiable traditional risk factor. Very interesting. That 50% of the people have no identifiable risk factor. It's remarkable, but it's true. So diagnostic imaging of those patients that have risk factors will, before we even start, miss 50% of the people that are going to have a heart attack. 50%. They get ignored. Okay, so if we direct our efforts only at those people who have traditional risk factors, we're going to miss 50% of them. So what are the risk factors for heart disease? Okay, as you can see and as you probably know, they're extensive. Men over 45, women over 55. Some people would drop those 2 numbers by 5 years. Family history of heart disease, well, because of everything else, that includes most of us. High cholesterol, history of smoking, high stress levels, sedentary lifestyle. I didn't put obesity here. I put it over here. So obesity, of course, and diabetes. The risk factors for cardiovascular disease in general, pretty similar. There's a lot of overlap, but the point is that when we look at the total array of risk factors, what we come up with is what my brother told me once when I told him the risk factors, which was, he said, so if you're 40 and you breathe, and that's pretty close to true. Okay, and remember again that 50% of the people that get a heart attack didn't have any risk factors. So the take-home point is that we can't ignore the patients who have little or no known risk factors, and most of the population has risk factors anyway, so why ignore them? Because sometimes we do. Well, there are lots of reasons why we might ignore them. Now here, the board has decided that this is much more cost-effective than giving you a heart scan, and if you can't read it, that's Madam Rosa sitting over there on the side who's going to let us know whether this person has any risk for heart disease. So we use the tools that we have to try to predict who the target market is for our prevention efforts. So we use risk assessment tools. We use a life check summary report, same thing, a risk assessment tool. We look at cholesterol, diet, blood pressure, and so forth to come up with an index that allows us to identify those patients on whom we should be focusing.